Welcome, Dr. El-Gabalawy.
Yeah.
My name is Alison Hoens, and it's a pleasure having an opportunity to speak with you today. Just for the purposes of getting us oriented here, can you give us a little bit of background of what it is that you do?
I'm obviously a rheumatologist at an academic center. I'm a clinician scientist in that a big chunk of my work is doing research. Once you get enough gray hair, you do a bunch of administrative roles. And I just finished one a few months ago as a scientific director of a CHR institute, which was quite a demanding job, a lot of travel. So it's nice to be able to hang around closer to home, at least for the most part. And I do what others do in academic centers. I teach medical students, residents, and so on. So it's a very fulfilling career and I think that our discipline has been very good at training rheumatologists and clinicians, but as a group, we're still struggling to train academic physicians who can compete in today's world in terms of research and so on.
Well, full disclosure, I actually had a little peek at your CV, and it is extensive. So I would say that you personally have been very successful in the research endeavors. I noticed that you've traveled quite a bit. You've been in different parts of Canada and the Maritimes and now Manitoba. You've spent some time in the Netherlands and in Bethesda, Maryland?
Bethesda, Maryland,
yeah. So was that all associated with your research, or?
Yes, except for the Maritimes piece, where when I first finished my training at McGill University in the 80s, my wife's a Maritimer, and we had kids, and we wanted to be closer to where we could have family support, which is an important issue, obviously, when you have two working partners.
Yes.
And we spent a wonderful time in Fredericton. I was in private practice, partnership practice with a colleague of mine, who's now retired, Dr. Jamie Henderson, and I kind of envy him in some ways, but I'm nowhere near
the retirement part.
I'm nowhere near retirement. So,
okay.
But yeah, and then the rest of it has been in pursuit of different academic activities. The time in the Netherlands was on a sabbatical, and it was wonderful to establish some collaborations with the Dutch and Leiden. They're wonderful people to work with.
That's nice to say, because I have some Dutch heritage,
yeah.
So that's good. Can you tell me your focus when you were over that time period? You've obviously undertaken a lot of research. If you had to condense it, you have 2 floors in an elevator to tell somebody beside you what your passions are in research. What would you say they are?
I think that's quite easy to answer, actually. The question that drives me now and all of the work that I do is, how does rheumatoid arthritis start? And much of the investment in human research and using animal models and using different approaches has been focused on that question. Certainly for the last number of years, we've gotten better and better in rheumatoid arthritis at treating people with the disease and achieving remissions. And we are tantalizingly close to being able to identify individuals who are at risk for developing the disease, and being able to do things that we're not capable of doing right now, which is to actually turn off the immune mechanisms that start the disease, and that's as close as we're going to come to a cure. So it's an exciting time, and you heard at this meeting from Dr. Ranjini Thomas from Brisbane,
yes.
who's a collaborator of ours, and focused on very much some of the approaches that may be in the foreseeable future successful in making the immune system do the right things and to stop doing the things that cause autoimmune diseases like rheumatoid arthritis.
That's personally of great value to myself, having rheumatoid arthritis, but also my daughter was just diagnosed a year ago, and my curiosity around that is, if you can identify, if you know potentially what what the triggers are, what the things that put somebody over the threshold to maybe going to have it versus actually starting it. Does that change? Could that potentially change how it's managed long term, or is it only for prevention?
No, I think that's a very important question, and I guess the way the one word I keyed in that you asked about was the issue of threshold, and we are now, at least in my mind, thinking that we have to try to understand that threshold, and understanding that is not an easy thing to do, because it's a complex, multifaceted threshold that involves many pathways and many cell types. But we know from clinical experience that individuals at the start of their rheumatoid arthritis and other autoimmune diseases, there's a variety of different events that occur that contribute. Pregnancies, infections, periods of stress. All of these things, I don't think we can predict those. Mm-hmm. What we can understand is the threshold, immunological threshold, in which any one of these stimuli is going to cause the disease to start. So the approach really would be one of not trying to identify every single trigger that's going to get an individual to there, but to understand at any particular time, where are they in terms of that threshold of having their immune system?
How close are they to tipping over the edge?
To tipping over the edge. Yeah.
Okay.
And so then it's that understanding will allow us to potentially modulate that threshold.
Bring it down.
So bring it down so that these events, unpredictable as they may be, will be less likely to tip them over into developing disease.
That would be very welcome indeed. And I'm sure it's welcome from a healthcare provider perspective as well, because obviously the less severe disease that somebody has, or if you can prevent it, or at least help to make it less severe, that makes it easier for you as well as for a person living with it.
Very much so. Very much so. And now I've been a little kind of corollary of that is I've been working almost exclusively for the last number of years with indigenous populations, and the reason for that is that rheumatoid arthritis is particularly prevalent.
Yes.
We have a clustering of all of the genetic elements and the environmental elements that we know are associated with disease. So it's made it an easier population to work with in terms of understanding how the disease starts, finding individuals who are at risk. The rheumatoid arthritis and other autoimmune diseases such as lupus are very much familial in that population. Mm-hmm. And you see many, many multi-case families. And we've now followed individuals, first-degree relatives of rheumatoid arthritis, indigenous rheumatoid arthritis patients, for many we've followed for more than 10 years, 10, 12 years. And we've got a pretty good idea in following these first-degree relatives who have a higher baseline risk than other people who don't have a family history about that threshold I talked to you about, and how that threshold evolves over time. And when they get very close to being at that tipping point that you alluded to.
Yes.
We'd like to get better at that. We'd like to add more to our model so that we're even better in being able to predict that. But most importantly, we'd like to be able to, if we do something at that stage, whatever that may be, we'd like to be able to know that we've done something. Because one of the problems is that if you were to wait with any one individual until they developed the first signs of inflammatory arthritis, the joints became swollen, and so on, you're waiting a long time. And we know in the individuals that we've seen develop disease, of the ones that we've followed, it's a matter of years. So designing clinical trials to look at prevention of a disease like rheumatoid arthritis is not an easy business, because you don't have all of the other...
It's complicated.
Yeah, it's complicated because you don't have all of the advantages of being able to count joints or look at inflammatory markers. So one of the real challenges we're facing right now is how to understand what are the components of that threshold, what are good biomarkers to tell us that an individual has gone up or down in that threshold, and whether whatever we do is
so sort of like the green zone, the yellow zone,
yeah.
the red zone.
Yeah.
So I have a question related to that, because you're working specifically focusing primarily on the indigenous population right now. What is your gut feel about the learnings from that population and how that may or may not be similar to other populations?
Yes.
Yeah. Do you feel like there might be some learnings that can extend to non-Indigenous populations, or do you think it will be pretty specific to that population?
Alison, that's a great question. I think there is a lot more similarities in how Indigenous people develop rheumatoid arthritis than there are dissimilarities, shall we say. The disease in Indigenous people that we've studied is almost exclusively seropositive, which means that everybody's got the anti-citrullinate protein antibodies, rheumatoid factor, and whereas in non-Indigenous populations,
it's a mix.
It's a mix.
Yes.
Yeah. We're keeping in mind that still 70% are have the same kind of phenotype where you have these autoantibodies. So yes, from that point of view, I think there's a lot of parallels. From the point of view of some of the social environment in which individuals develop this disease, there are some stark differences. There's no question that the cultural and the social context in which rheumatoid arthritis occurs in Indigenous people is quite different than it occurs in non-Indigenous people. And we know that that has a profound influence on the outcomes and the uptake and of treatments, the perspective on how much risk one is willing to take with treatments versus benefit, and so all of these things we have to understand in a much more specific way for the Indigenous population, and our findings may well not be kind of translated to other populations. But the basic understanding of how the immune system becomes dysregulated, shall we say, and how we can potentially turn it away, I think these are applicable to rheumatoid arthritis everywhere.
So maybe the same learnings then could then be tested in other populations at a future date.
Absolutely.
Yes.
Absolutely. And there's now quite an international assault, shall we say, on this preclinical stage of RA. We've got some tools that we need to get better, but we're faced with very much that important question of if we give people whatever we give them, and there's a Dutch study looking at giving one shot of rituximab at a critical point before the disease starts to see if that turns things up.
A single injection.
A single injection. There's another study looking at abatacept. And these are treatments that work in rheumatoid arthritis, and they've just been pushed back earlier and earlier. There's a study led out of Denver, Colorado, Dr. Kevin Dean and his colleagues, looking at hydroxychloroquine, which is a relatively safe medicine that's been used extensively in rheumatoid arthritis, lupus, and so on. If we used it at an earlier stage, when people just have the autoantibodies but don't have disease, does it do something unique at that stage?
Does it have a protective effect so that they don't tip over that threshold?
Exactly.
Is that what you're saying?
Exactly.
Yes.
What's very important to understand is what risks individuals are willing to take to prevent rheumatoid arthritis.
And that's pretty individual.
That's pretty individual, and it may differ in different cultures. And I think that this is one of the things we're starting to understand. We've held focus groups with Indigenous people, the relatives of Indigenous people with rheumatoid arthritis, and the risk tolerance is probably somewhat different than possibly in other populations.
And interestingly, my daughter and I both participated in focus groups before she developed rheumatoid arthritis. For that, what would she be willing to take take a medication in order to prevent it? There's age differences. It's not just cultural, right?
Yes, very much so.
We are.
Yes.
So,
well, thanks for bringing that up. I think that, I think that the way you think about it versus the way your daughter thinks about it, I think is really quite important.
Yeah. So I'm conscious of the time. I know you have to get back to another component of the meeting, but I'm wondering, Anita, if there's any questions from the audience at this point.
In terms of arthritis healthcare, what are some of the challenges about working with indigenous population?
Great question. Thank you for that question. The challenges of working with indigenous people, delivering good health care for indigenous people, especially in the rheumatic diseases, chronic diseases, is number one, geography. I think the geographic dispersal of Canada in general, but particularly indigenous people living in communities that are often quite remote from the major centers that have the arthritis specialists. That becomes challenging logistically in particular, and you really have to have a commitment. At our particular institution, the efforts of Dr. David Robinson, where he actually has gone and undertaken clinics in remote areas for more than a decade now, has made a very big difference. But we know that in many areas that's simply not a tenable solution. So a number of other approaches are being evaluated. Telemedicine obviously is a very appealing one, but I think that anybody who has rheumatoid arthritis recognizes that there's very little substitute for having an experienced practitioner sitting in front of you with his or her hands on your joints to get a feel.
3D is preferable.
3D is definitely preferable. Yeah. So one of the things we're quite interested in is the training of local health providers, nurse practitioners, and so on, in some of the methodology, such as assessing joints and assessing inflammation in joints and so on, that can help bridge that gap in between, that will allow for remote access. The transportation costs for individuals with chronic diseases like rheumatoid arthritis are staggering. I was just hearing some numbers about the non-insured health benefits program, which is what funds the care of indigenous people. They have a $100 million budget just for travel, and I think that we've got to look at this carefully and think about how could we do this better, as opposed to having individuals be transported.
That's a really good point,
yeah.
Because it's not just getting access to the care,
Yeah.
but and you can have the funding to be able to travel to a major center, but that takes you away from your community.
Yeah.
And that takes you away for children from their
Absolutely.
friends, from their schools, from your employment there, all kinds of things.
Yeah.
Are there any other questions, Anita?
Where do you see the most potential in terms of arthritis healthcare for the indigenous population, and where do you see arthritis healthcare in 10 years in this population?
Again, a great question. We see in the indigenous population a disproportionate amount of chronic disease. And it's not just rheumatoid arthritis and the high prevalence of rheumatoid arthritis. I think everybody is aware that there is a staggering prevalence of type 2 diabetes, cardiovascular disease, and we're just starting to scratch the surface in terms of numbers with cancer, tuberculosis. So the burden of chronic disease is huge in the indigenous population. Now, what I see the things moving ahead is being able to tackle multiple chronic diseases simultaneously using healthcare delivery that doesn't just focus on
A single disease,
but focuses on the whole package of a chronic disease that is the curse of our indigenous population. So working with other disciplines, with the endocrinologists, with the cardiovascular specialists, with the cancer specialists, to understand better, both from a mechanistic point of view, how can we do things that impact on multiple chronic diseases, as well as patterns of healthcare delivery that are able to address these multiple chronic diseases. That's how I think we're going to really be able to move ahead with better models.
Thank you. I think what we've heard today is that a lot is being done, and that there's, the future is actually a little bit in the present right now, and not that far away. Because
I like to think so.
Yeah. And I thank you for your contributions across the country, and for coming over the mountains on a snowy day in Vancouver. And we look forward to speaking with you at the next conference.
Thank you very much.